Scientific Director of the Mass General Research Institute. We record this just so we have it for fun, and we also love to have little snippets of our slammers that we use for different things. If we're going to use it for anything, of course, if you're speaking, we'll let you know. I hope everybody will turn their cameras on because this is meant to be interactive. When we started doing the science slams a few years ago, and we typically are at a bar, so it's not as good like this, although we have found that we get a lot of people at these virtual science slams, and it can be fun. Okay. The interactive part comes when our guests are speaking. And so the idea here is to really give people an opportunity to spend no more than 3 minutes talking about their science in a way that everyone can understand. So, you know, I always say, think about like you're trying to explain your science to your grandmother in like 3 minutes, like just your little pitch about what you're doing and really why it's important and why it's cool. And so today's Science Slam is co-sponsored by the Yvonne L. Munn Center for Nursing Research. And we have to give them a big, huge round of applause and shout out because they really came to, brought everything they had and recruited 6 different nurse slammers. So we're really excited to hear from them today, and a lot of people listening. So it's really great. And the Division of Clinical Research. So I see Maurizio's here. Thank you, Maurizio, for co-sponsoring with us today. So some housekeeping. I'll call on the slammers. They'll start. Gloria, where's Gloria? Gloria's there. Does everyone see Gloria? You might want to pin Gloria if you don't know how to do that. If you're slamming, if you hover over Gloria and click those 3 little dots in the box, you can pin her because she's your timer. Can everyone see her who's slamming, right? So that's going to be your timer. So you know when you're out of time for your little presentation. And like I said, feel free to use props, whatever. Everyone who's listening, the reason we want your cameras on is because we want you to use your reactions. We have thumbs up or clapping, or we thought maybe you could put up your hand if you don't understand. It's important for the speakers to know when they're saying stuff that no one's getting, right? Like so typically, if we're all in person, people can be yelling like, what? Huh? I don't understand that. But on Zoom, it's a little harder for multiple people to start yelling out. So put up your hand if you don't understand. And so that way, if all the cameras are on and the speaker sees a lot of hands go up, they'll realize they use some word that no one has any idea what it is. Okay, so that's really the idea, is to just give people a chance. It's a quick way in an hour to spend a little time at the end of the day learning about what your colleagues are doing at the institution. We usually have 9 or 10 slammers speak for 3 minutes. It gives a nice overview of the work going on, and so we're really excited about it. My team, did I forget anything?
If you are a slammer and you are using props, we would recommend maybe disabling your background if you are using one, just because, as you can see with my hand, sometimes things that you have in front of the camera get lost with a background. So if you're not using props, don't worry about it. But if you are, maybe just turn off the background while you're slamming.
Definitely.
Hey, Sal.
Yep.
I'm doing okay. How about you?
Good. How are you? Okay. So why don't we go ahead and get started? Okay. So we had a volunteer, Sarah Luby, to go first. So which is great. So everybody give Sarah a big hand. Okay. So Sarah, watch Gloria. She'll be your timer. And I'm going to ask everybody, I don't have an introduction for everybody prepared. It's supposed to be casual, but just tell us who you are and where you work. And obviously at Mass General, but I mean like, what your specialty is or something before you tell us a little bit about your work. Okay?
Okay.
All right, Sarah, I'm turning it over to you. So everybody get ready with your reactions button and your hand and everything else. So, all right,
Okay,
Sarah.
great. Hi, everyone. Good afternoon. My name is Sarah Luby, and I am a nurse scientist in the Munn Center for Nursing Research and a clinical investigator in the metabolism unit here at MGH. So, who doesn't love sweets? Well, my program of research evaluates nutrition and metabolic and heart disease complications in people with HIV. And there's an old saying that you are what you eat. And for those living with illnesses, including HIV, eating too many sweets or added sugars each day over time may seriously impact overall health. Let me tell you why. There are natural sweeteners like something called fructose found in fruit that are healthy. And then there are added sweeteners like high fructose corn syrups that are added to baked goods. Early research studies have shown that people with HIV tend to eat more added sweeteners than recommended and have poorer diet quality compared to similar people without HIV. Also, those with HIV have a greater risk for heart disease than those without HIV. And one study showed that increased intake of added sweeteners led to something called coronary plaque, or a buildup of fat in the arteries that feed the heart, leading to heart disease. Here, let me show you what this looks like. What you're looking at here is a healthy artery or blood vessel leading to the heart, where blood can travel seamlessly down to perfuse the heart so it can pump to the rest of the body. However, plaque can form from an artery if a person eats too much fat, has bad exercise habits, or smokes, or sometimes because of family genetics or different illnesses, this can happen. And when this happens, the arteries get clogged and the blood can't perfuse to the heart. So add to this too much sugar in the diet, and now we have a real problem, which can lead to heart disease. So given this information, it's very important to better understand factors that may influence added sweetener intake in this population to create feasible and sustainable nutrition interventions. So in our study, we evaluated knowledge and intake of added sweeteners in people with HIV and explored association of these factors with age, race, sex, education, income, and access to fresh fruits and vegetables. We looked at the influence of these social demographic characteristics with sweetener knowledge and intake. How do we do it? We conducted a US national survey by advertising on websites frequently visited by people with HIV. We had 900 people from 46 US states complete the survey. Findings from our statistical analyses showed, starting with sweetener knowledge, that female sex, being of diverse racial and ethnic background and having less than a high school diploma, significantly associated with lower sweetener knowledge score. In terms of sweetener consumption, being of diverse racial and ethnic background, younger age, having a higher weight or BMI, lower income, reduced access to fresh fruits and vegetables, and lower sweetener knowledge score, significantly associated with higher sweetener consumption score. Findings from our study highlight the need for consideration of specific demographic and inequitable social circumstances when developing nutritional lifestyle strategies, something I am very passionate about. Thank you for your time.
Excellent, Sarah. Yay, everybody give her a big round of applause. Okay, Sarah was our first one, but she's going to be a tough act to follow. Lovely use of props. Love the props. Very nice. Excellent, excellent job, Sarah. Okay, we'll go on to our next slammer. Let's see who's next on my list. Jennifer Duran. Where's Jen?
I'm here. Thank you.
Oh, I see you over there. Okay, great. Okay, good. All right, Jennifer, I'm turning it over to you. Gloria, are you ready? Jennifer, you can see Gloria, right, for the timer?
Great. Well, that's a tough act to follow. Thank
It
you,
is.
Sarah. I'm a first-time slammer here, so bear with me. My name is Jennifer Duran. I'm a nurse here at MGH in the newborn ICU. My work recently in global health has taken me halfway around the world to a remote area in Uganda. The purpose of this fellowship was to assess the educational needs of the staff working there. As I acclimated to my new surroundings, it was hard to ignore the numerous babies that were dying as a result of being born prematurely, and this weighed heavily on my mind. So I focused my efforts towards understanding the problem. You can't find a solution to a problem until you know exactly what the problem is. A little background. 3 million babies die each year around the world from being born too early, and where these babies are born certainly impacts the outcomes. In Uganda, you are 7 times more likely to die as a preterm baby in comparison to the United States. The resources simply are just not there. Upon returning home after this first fellowship, I began my work on a new educational program aimed at reducing the newborn deaths in this hospital. Additionally, I developed a CPAP device to return with to begin the initiation of this life-saving therapy. So what is CPAP? CPAP stands for Continuous Positive Airway Pressure. It offers the opportunity for a preterm baby's lungs that look like this to look like this. This is a fully inflated lung. This is about all I have for props compared to Sarah. That can help sustain a newborn's life. Babies born early lack the ability to keep their tiny lung sacs open. CPAP affords this opportunity, thus increasing newborn survival. This device was created to function off a simple water-filled jar, like this one that I have here, using oxygen or any compressed gas to create the pressure. These small prongs, you can see my little baby, sit comfortably in the newborn's nose to allow for this pressure to open up their fragile lung sacs. I was careful not to consider potential solutions requiring electricity, as this is a resource that is at times not available and quite uncomfortable for the nurses working. Today, staff continue to increase confidence in managing these preterm babies, as well as decreases in mortality, which is encouraging. What's unique about this project is that this is solely a nursing education initiative and a quality improvement project. MGH has a long relationship with this hospital in Mbarara, Uganda, but this is the first newborn ICU project. What I've learned about this work is that education is the resource that can never be broken, lost, or taken from us. It empowers us to seek solutions where there appears to only be problems. This work is rewarding on so many levels. Thank you for your time.
That was really great. I'm getting a lot of feedback. Everyone else? Okay. Love the lungs. Excellent use of props too. Balloon lungs. Love that. And I really loved what you said about how this is a nursing education thing, like that the nurses are making such a difference in that hospital. That's really awesome. Yes, and everybody keeps putting things in the chat, which is great because we can capture the chat. So I think it's, please keep putting, if you have any questions that you might want to ask people, you can pop them in the chat and then we could get them to them. So I'm really glad that people are using the chat. All right, so our next slammer, again, just please introduce yourself and where you work is, I hope I say your name right, Zoray Amusgar. Is that right? Oh,
yes.
There's, hi Zoray, how are you? Did I say it right, Zoray?
As close as possible, yes.
Okay, good.
Yeah.
What as close as possible? Okay.
It has HNR, both constant, not vowel, so it's not gonna be easy.
So tell us where you work, Zoray.
Yes, I work at MGH in Department of Radiation Oncology. I'm a fellow here, and I mostly focus on immuno-oncology and technology development. Should I start? Okay.
Yes, please start.
Okay, sure. So inspired by really great work of Tolstoy, I would just like to say happy families are all alike, and every unhappy family is unhappy in its own unique way. In a healthy society, we have a regulatory body, a government that orchestrates a set of laws to be enforced across the society. And part of its aim is protecting and nurturing its organ, the family units. Our body largely functions the same. Just like a society, we have continuous changes in our organs. We have developmental changes as we age, same as a society progresses through timeline and time courses. And then we have multiple smaller communities as families that join together, and we grow together as one unit, as a body. We have organ development and aging, but then comes to cancer, which is mostly what I focus on. It's a collection of unhappy families who they decide together to take more than their share at the cost of the society. every level of this unit is abnormal, from its interaction to other family members to its function and priorities. This unhappy family decides to grow and extend its state of problem to other families, starting from the close neighbors onwards. And the generation of these many happy families that are not alike and they are unhappy in their own unique way, they form a cancer. So one family suffers from abusive relationship, one becomes abuser. So this collection, when it gets to a point that it bypasses the immune system, which pretty much polices the society, the problems begin. Having in mind that police also has multiple corps. We have a fighting squad, we have a peacekeeping unit, and so on. At some point, the fighting squad gets tired and it becomes hard for it to fight the disease. It's like the CD8 cells in the body that they get exhausted. In the worst case scenario, the CD8 cells also join this, they collude with these unhappy families and they continue. So, and they start producing pro-tumor factors, just like what will happen in a society if this happens. And then we have these peacekeeping squad, which are not, pretty much are like a blind justice called T regulatory cells. They tend to maintain organs in health, but when it comes to the disease, because they really don't fully understand very well where their priorities are, they don't change their direction. So in that case, cancer develops further, it takes over the body. And one of the diseases that it's extremely crucial in it is glioblastoma, that pretty much if anybody is diagnosed with, it's pretty much a death sentence. We have about 15 months of time to live with that. So what I discovered is in this case, we can re-educate this kind of peacekeeping corps. In a way, they regulate their function. When they get hired by the police force, they are educated, they have a very good affinity to detect things, but they don't act on it. So I give them an action to join forces with the fighting unit and remove the cancer cell, rather than I remove the peace squad that sometimes with drugs we do. So, and now I'm trying to develop technology such that this whole system can work in an organized way, unique to an environment rather than everywhere else, to avoid generating systemic toxicity to the body. Thank you, everyone.
Great, thank you, Zoray. That was great. Interesting analogy. I liked where you went with that, you know, in the peacekeeping squad and the other squad. That was really great. Look forward to learning more about your work as you continue. Okay, so our next slammer, let's see, I have to find someone around the screen, is Inez Luciani McGilvray.
Close enough, close enough. I was hoping you'd pick me because I want to be next to get this done.
How say your last name, Inez?
My last name is Luciani McGilvray.
McGilvray. I don't know
Yes.
why I couldn't get that out. It's not that hard.
That's
McGilvray.
all right.
Inez, Inez, I have to say hi. This is my mom's best friend from the Mass General Emergency Room. So good luck, Inez. I love
Thank
nursing.
you.
And it's great. You're going to be great.
Okay.
Thank you. Thank you.
Victoria, she's your timer.
Yep, so my name is Inez McGilvray. I'm a staff nurse in the emergency department, and I've been here 36 years. I am #1 in my department out of all the nurses for seniority, out of 280 nurses. I've had multiple roles, and most recently working with the post-discharge calls, which I love, and I love this kind of work. So anyways, I'm going to begin. So has anyone ever been a patient in the emergency department and then discharged home and then wondered to themselves, what do I do next? What is next? And you think to yourself, oh my God, I've been there so long. I'm tired, I'm hungry, I'm thirsty. I couldn't have any food because of all the tests that I needed to have done. And then when the healthcare provider reviewed my instructions, I just couldn't comprehend. I couldn't understand, and I really just wanted to go home. And I really don't want to go back to the emergency department. But then all of a sudden, the next 24 hours, you get a call from an experienced RN that provides a post-discharge call. And then you think to yourself, wow, this is really great. The RN reviews the ED visit and the follow-up. They ask how you're doing. They provide reassurance, reinforcement, and resources. The RN explains how important it is to follow up with your provider and all the many benefits that occur from that. The RN can provide specialty and contact numbers that you may need. The RN can also help with referrals to things like the virtual observation unit or the partners mobile unit. These are all alternative pathways so patients don't have to come back to the emergency department. The RN can also help facilitate appointments. They collaborate with other healthcare providers, such as doctor's offices, and they can help with any barriers or challenges that occur with the follow-up. And they also provide these three-way calls with non-English speaking patients. They even offer a HIPAA certified volunteer phone call, 72 to 96 hours after the RN discharge call. And this volunteer sits side by side with the RN and basically just provides a reminder phone call. There's no medical advice that's given by this volunteer. The volunteer has a script that they utilize. And if there are any questions or challenges that occur, the RN is right there and can deal with it in real time. With our project, we took a sample size of about 380 patients upon discharge, and we found that only about 48% of them really knew what to do or who to follow up with. So with that project, what we did was we included a modification to this nurse-led discharge call by adding a HIPAA certified volunteer to help increase the follow-up with their providers from 48% to over 60%. And we were hoping with increasing follow-up, we would get decreased revisits and hopefully things that affect these capacity challenges hopefully wouldn't be as bad. So what I'm going to do basically is just give you an example of how these calls work. Basically, I would call the patient, RN. My name is Inez. I'm a discharge call nurse. I'm calling from the emergency department to see how you're doing since your recent visit. And I want to help you with your discharge instructions and make sure you understand what you need to do. Patient. Oh, thank you very much. I really appreciate this. I was wondering what to do. I was scared. I wanted to get out of there. I really wasn't paying attention. I'm glad you're calling me. I don't even have the discharge instructions anymore. I lost them. There were so many papers. I think I threw them away. So I'm glad you're calling me and trying to help me. I don't even think there were contact numbers on the paper. RN? No problem. I can help you. We can help you with all of this. We can review your instructions, review your visit, give you the contact numbers. We can even provide you with a volunteer over the next 72 hours to call you again and help remind you to follow up with your provider. And if you have any problems or challenges, we can certainly help deal with that. Thank you very much. Thank you very much. I'm looking forward to all this information. I appreciate you calling me. Mass General must really care about their patients to have all this concern. Volunteer phone call, 72 to 96 hours afterwards. The volunteer basically states, hi, I'm a volunteer from Mass General. We're calling to help remind you to follow up from your emergency department visit. We care about you, we care about our patients and want them to get the best possible care. And that includes following up with your provider. Have you followed up with your provider? And would you like to speak to the RN if you have any more problems? He or she is sitting right here next to us. And we found with all of this, our patients really loved these phone calls. They thought we were the best thing since sliced bread here at Mass General Hospital. That's it. Thank you.
Excellent. That was excellent, Inez. So important. It seems like I can't believe we haven't always done it, right? It seems so great. And I'm sure that you guys make that all of the patients feel so important. Do you have trouble getting in touch with people?
We usually out of the phone calls, we probably reach 3/4 of our patients. So we do make 2 call attempts and then once that's done, the call gets dropped. And I do want to mention, I forgot to mention that if anybody wants to look at any of this data, we published 2 articles, Journal of Patient Experience and Journal of Emergency Nursing. All the details are in those articles.
Excellent. Congratulations on
that. With the help of Jen
Great.
Cahill, of course. Jen Cahill was instrumental in helping me with that.
Great. Really, really great. I love hearing about all these nurse-led initiatives. The research that goes on is so important. Okay, our next slammer is Hyunju Song. Where's Hyun?
Hi, right over here.
Oh, there she is. Okay, great. Tell us where you work and what you do, and then go ahead and get started. Where's Gloria? Gloria's moving around my screen. Okay, there she is.
Good afternoon. My name is Henshin, and I'm a recent college graduate from Carnegie Mellon University. I'm working as a technical and clinical research assistant at Dr. Yu's lab at Brigham and Women's Hospital, where we're studying the role of different cell signaling molecules in pulmonary arterial hypertension. So pulmonary arterial hypertension, or PAH, is a disease characterized by high blood pressure in the pulmonary artery, which is a blood vessel that connects the right side of the heart to the lungs. In PAH patients, these vessels either constrict and become narrowed, are blocked, or destroyed. So take this paper towel roll, for example, and let's pretend this is the normal size of a healthy pulmonary blood vessel. Well, in PAH patients, the inner surface area of the blood vessel drastically decreases, let's say to the size of this pasta noodle. Well, as you can imagine, that will slow down the flow of blood traveling through the vessel. And as a result, the heart has to work that much harder to pump the same amount of blood, hence increasing blood pressures and resulting in heart failure. Currently, the only way to diagnose PAH is through a process called right heart catheterization, which is a pretty invasive method. It involves inserting a long catheter through the jugular vein in the neck area, or sometimes through a vein in the arm or the groin, and the catheter is guided all the way to the heart and pulmonary arteries. The entire procedure lasts for about an hour, and the cardiologist may ask the patient to cough, hold their breath, and perform other activities to assess blood pressure during these activities. And while this procedure is relatively safe, it is invasive and can result in skin reactions, blood clots, stroke, lung collapse, pulmonary artery rupture, and other undesired complications. So in my lab, we're researching a way to diagnose PAH less invasively and without the risk of all these aforementioned complications. And one way we're doing this is by using a radioactive tracer and conducting PET CT scans. And while this particular radioactive agent that we use as a tracer has already been approved by the FDA for detecting neuroendocrine tumors, it hasn't been approved yet for PAH. So this tracer has an excellent affinity for white blood cells and macrophages, which are commonly found in the blood vessel linings of the lungs of PAH patients. And since blood vessels of the lungs are difficult to biopsy unless a surgery is involved, we're using this non-invasive technique as a means to probe and detect certain types of inflammation caused by white blood cells. And by determining if these inflammatory cells are enriched in the lung vessels, we might be able to diagnose patients in a less invasive manner and also potentially design better treatments for PAH patients through targeting these cells. Currently, we're finalizing the results of this study, and after we scan one more patient and 2 more healthy controls, we'll be finished. But our findings thus far have been very interesting. We found a significantly higher uptake of this isotope in the lungs of PAH patients compared to that of healthy controls. And we're really excited about potentially opening up a door to less invasive diagnostic methods for PAH patients. Thank you.
That was great. Thank you so much. Excellent. Yeah, excellent talk. And congratulations on your graduation. I don't know. I don't want to go. Maybe our youngest slammer today. I'm going out on a limb here, but you guys can correct me if I'm wrong, but I'm just guessing. So we're glad to have you, and I'm glad that you saw our announcements and decided to join us today. Excellent work, interesting research, and I'm sure that I hope that you're planning a future in biomedical research of some sort. Yes?
Yes.
Excellent. Great. Well, we're glad to have you today.
Thank you.
Okay, so our next slammer today, let's see, we're halfway through our time already. This is going perfectly. Our next slammer today is Elizabeth Moover. Where's Elizabeth?
Hi, I'm right here.
Oh, there she is. Hi, Elizabeth.
How are you?
Good. How are you? So
Good.
Thank you for joining us. So go ahead and take it away. Tell us where you work, and I know you're at MGH, but tell us where and what you're doing, and then go ahead and tell us your story today.
Sure. So my name is Liz Moover, and I'm a staff nurse and the attending nurse in the medical ICU on Blake 7. And I was lucky enough to participate in the AACN CSI Academy. And we identified a problem on our unit and really in all ICUs, and kind of came up with a way to fix it. So I'll be talking about using weighted blankets in the intensive care setting. Imagine being in the intensive care setting with an endotracheal tube, also known as a breathing tube, down your mouth, and you can't speak. You're on multiple sedating medications and you're on them for days. Your medical team decides it's time to stop your sedating medications, wake you up, and take that endotracheal tube out. Your nurse puts restraints on your wrists so you won't pull your tubes out, and then turns the sedation off. You begin to wake up. You don't remember where you are or why you're here. You're disoriented. You may even think you're on another planet. You start to squirm around, you get agitated, and you don't know why you're here. Your medical team decides to give you a small dose of medication to keep you calm. You become unsafe and in the bed, and you're at risk of pulling things out, lines, tubes, and other devices. Your medical team decides to fully resedate you. How can we make this process better for our patients? In the medical ICU, we trialed using weighted blankets. I'm gonna put one on. Sorry, they're really heavy. So trialed using weighted blankets on our patients who are ready to be extubated and have their sedation turned off. There's limited research on weighted blankets in the acute care setting. One thing we do know is that weighted blankets help ground a person. They help increase reality orientation, self-soothe, calm a person, and provide comfort. Weighted blankets can provide warmth, deep pressure, tactile and visual stimulation. They create a feeling of being held. Who doesn't love a good hug? We identified patients daily who were nearing extubation, so meaning taking that breathing tube out, and who are ready to have sedation weaned down. We asked the nurse to apply a weighted blanket before weaning sedation. We found that the blankets were helpful in our patients who were also agitated, restless, and we found that our patients moved from a restless state to a more calmer state. We actually had a decrease in about 22% decrease of using our continuous sedating medications. And there was a 51% decrease in using as needed medications. We also found that patients came off the ventilator sooner. We decreased our ventilator days from 5.3 days to 4.8 days. Patients told us they felt safe with the blanket on, they felt comforted, and nurses felt that their patients were actually able to sleep better with the blanket on. So to recap, using a weighted blanket on your patients who's coming off sedation and who most likely are confused, restless, agitated, and scared might help keep the sedation off and get that breathing tube out sooner and get them home sooner. Thank you.
Excellent work, Liz. Again, such a straightforward fit, such a straightforward issue. How long have weighted blankets been around? How many people have them at home? People have weighted blankets at home? I see hands up, right? Somebody wrote, I love my weighted blanket. So I see them in the stores all the time. I've never actually tried one, but this sounds like a remarkable use for them. So again, just an observation from watching patients, and such a incredible research project. So thanks, Liz, for presenting to us today. And again, I hope everybody's reading the chat. Some really great comments, again, really highlighting the remarkable work of our nurses. Okay, so I was wrong in what I said about Hyun earlier, because I was chatted that our next slammer, Miriam Trigo, where's Miriam? There she is.
Yeah, I'm right here.
Okay. Miriam, wait, I just lost you. Oh, there you are. Okay, good. So Miriam is a summer research trainee program participant. So Miriam, I don't know where you are in your education. If you are still in undergrad.
I am, yeah. And I didn't know the introduction was included in the 3 minutes, so I might be a little over, but I will try my best. So okay. I can introduce myself right now.
we all have time. So Miriam, so I was wrong, Hyun, you don't get the award for being probably the youngest of our slammers today, because we have Miriam. So Miriam, we're glad to have you. Please tell us where you're working this summer, whose lab you're in, and a little bit about the summer research trainee program. And we look forward to hearing about your work. So take it away.
Sounds good. Thank you for having me. So my name is Miriam Trigo, and I am a senior at Stanford University, but this summer I moved across the country to do research in the neuroanesthesia lab of Dr. Johnson Akeju in the anesthesiology department at Mass Gen through the SRTP program in the Center for Diversity and Inclusion. I'm going to present on the idea for the research project I will be completing this summer and on identifying biomarkers for delirium in elderly cardiac patients. So imagine you're visiting your grandfather at the hospital the day after a successful heart surgery. Strangely, when you get there, you notice your grandfather anxiously looking around the room, and you hear him saying, "Birds on the wall, birds on the wall." When you try to explain to him that there are no birds anywhere nearby, he suddenly falls asleep midway through your explanation. This is very odd behavior of your grandfather. So you let the doctors know of this behavior and they examine him. They let you know that your grandfather has unfortunately developed delirium. And you wonder, what is delirium? And why did your grandfather develop it so quickly? As illustrated in the scenario, delirium is a serious and sudden change in mental abilities. These changes cause confused thinking and reduce awareness of your surroundings. Delirium is a common problem in elderly patients, especially after severe illness or surgery. However, it is estimated that about half of delirium cases go undiagnosed. Delirium can last a short time, but sometimes it can last a lot longer, and it can have long-term detrimental effects, especially if undiagnosed and untreated. Our lab is currently looking for ways to identify patients who are at high risk of developing delirium after cardiac surgery. Our hypothesis is that we can analyze blood samples of patients who are about to have surgery, and we can look for elevated levels of a protein that is correlated with delirium. These proteins are known as biomarkers. To illustrate this idea, let's take a look at the following example. Here, we have two pieces of paper that are wet in the middle. These two pieces of paper represent two different patients. These patients are elderly, they have heart conditions, and they're about to undergo heart surgery to address those conditions. And the pieces of paper are wet to symbolize the susceptibility of these patients for developing delirium. So let's say that one coin represents 1 unit of this biomarker, and the patient on the right has 1 unit of the biomarker, so the paper doesn't break. While the patient on the left has 6 units of the biomarker, and we know that patients who have 3 or more units of this biomarker consistently develop delirium, as symbolized by the breaking of the paper. Sorry, it dried. However, since we know that the patient on the left has elevated levels of this protein, we can act ahead of time and prevent this patient from developing delirium. Perhaps we can give them some medication, or we can help them stay mentally active after surgery. And identifying these actions will prevent the development of delirium in these patients after surgery. So overall, by having this biomarker, we can know how to better serve our patients so they can have a more successful recovery. That's the gist of my research. Thank you so much for listening.
Nice. Thank you, Miriam. Excellent, excellent. That is really great. I'm sure all of our nurses and clinicians here have encountered patients with exactly what you are describing. And I hope everybody's familiar with the summer research training program that's been going on for many years at the hospital. It's really great. And Miriam, I will get to see you later in the summer because I always get to talk to the training program at some point. So thank you for participating today. It's really great that you're here. I'm glad you saw the announcement come out and decided to join us. And excellent work, really excellent work. We hope that you're able to find something by the end of the summer. And I agree with what Sarah just said. Great use of props as well. Everybody's doing really well today with that. So, all right, our next presenter is Kirsten Dickens. Kirsten, where are you? Oh, there you are. Here's Kirsten. So Kirsten, can you see Gloria with the timer?
Yes, I can. Thank you. Can everyone hear me okay?
Yeah, you sound great. So go ahead and get started.
Perfect. Okay, here I go. So my name is Kirsten Dickens. I'm the Cannell Postdoctoral Fellow in Nursing Research at the Munn Center, and also a nurse practitioner in the Home Hospital Program at Mass General. Today, I'd like to share with you some thoughts on the big question that drives my work, which is how do we ensure that all people have a fair chance to live a long and healthy life? My unique approach to answering this question is to use numbers and human stories to see trends in large data sets and to understand what these trends mean to a patient's daily life. From 2015 to 2019, I was a PhD student in Chicago. Go Sox, Cubs, Bears, Bulls, Hawks. I also worked as a nurse practitioner in the various homeless shelters across the northwest and south sides of the city and the Cook County Jail. I saw firsthand the inequities and what it means to live a long and healthy life. You may have heard the term zip code disparity, or the idea that life chances differ, quite literally, block by block. Zip code, used as a proxy for all of the social factors that impact a person's life, is now recognized as more important in determining health than genetic code. Health is not the result of solely one's genetic makeup, but rather the conditions to which one is exposed on the daily. In the distance of just 1 mile, your life can be expected to be shorter or longer by 10 years, depending largely on social conditions, poverty, racism, ageism, sexism. Social conditions profoundly impact one's chances to live a long and healthy life. When I moved to Boston strong, I wanted to delve deeper to understand what it looks like in a homeless population, and more specifically, in homeless women, a group on which little research focus has been placed. Let's start with a reference point. In the general population of the United States, the average life expectancy at birth is 78 years. For men, it's 75 years. For women, it's about 81 years. For my study, I looked at a group of over 60,000 homeless persons in Boston from 2003 to 2018. In this group, over 7,000 homeless persons died. The average age of death in this cohort was only 53 years of age. In men, it was 55 years of age. Women, on average, died earlier, at around 50 years of age. In other words, homeless women died on average over 3 decades prior to the average female life expectancy in the United States. About a third of deaths were substance use related. The next leading causes of death included cancer, heart disease, and liver disease. These disparities were so tough to understand, so I sought stories to fill in the details. I talked with low-income women and homeless women about their unique strengths and challenges. Women shared their stories of fear, of mistreatment, of trauma, and also the incredible resilience within this struggle. One woman shared, quote, "I've fallen so many times in my lifetime. Added on to that, the loved one's death, but still, I rise." The task now ahead of me is to use these numbers, and again, stories, to develop solutions that promote equity and opportunities to live a long and healthy life. It is the idea or belief that this is in fact possible, the dismantling of disparities and the creation of systems and contexts that promote equitable health outcomes. This is what keeps me both motivated and also still in love with my work. With numbers and stories, we can promote equitable life opportunities that can be experienced fairly across all members of society.
Thank you, Kirsten. That was awesome. Very, very important work, very moving. I love the move from Chicago to Boston, and it's really great for the volunteer that we have you and that you're undertaking this important work. And I am a geneticist, so now I loved your zip code is more important than genetic code when it comes to living a long and healthy life. You know, as a geneticist, I would think genetic code is the most important thing, but I learned something today. I'm learning a lot today, actually, from listening to all of you, but that was really important. I think it's a really important message. So thank you for choosing to do your work here. It's really remarkable, really remarkable. Okay, so our last slammer of the day is Rebecca Hill. Where's Rebecca? Oh, there she is. Excellent. Hi, Rebecca.
Hi, how are you?
Good, how are you? Thank you for joining us. So
thanks for having me.
Bringing up the end. You have some big I mean, there's been some amazing presentations and a really beautiful overview of work that everyone's doing. So we look forward to hearing you.
So awesome and impressive. Thank you so much. I'm Rebecca Hill. I'm a nurse researcher and associate professor at the MGH Institute of Health Professions. And my research is all about tongue tie. It is a minor congenital oral anomaly that can have significant consequences. So we found that it occurs in approximately 8% of babies. And when it's present, you can see here the tongue. This is the extra tissue under the tongue that adheres the tongue to the floor of the mouth. So when that tongue tie is present, the tongue cannot lift appropriately. When the tongue can't lift, there are issues for both the baby and the mom in terms of breastfeeding and infant feeding in general. The research to date has not provided a strong enough argument to create any universal screening guidelines for tongue tie, and I hope to add to the research and provide sufficient evidence to support that this mild anomaly can have significant implications for moms and their babies. So to date, my research has focused on trying to improve our understanding of the symptoms that babies and their breastfeeding mothers may encounter if tongue tie is present. What I've found so far: for mothers, breastfeeding is more commonly a very difficult and painful task. Mothers are more likely to experience pain when the baby latches onto the breast. She's also more likely to develop cracked, creased, blistered, or bleeding nipples during breastfeeding. This relates to the baby's inability to lift that tongue, so they end up biting rather than sucking on the nipple or creating additional friction onto the breast. Mothers frequently need to use a nipple shield or switch to bottle feeding because of those difficulty symptoms. I found that these symptoms are significantly reduced almost immediately after the tongue tie is corrected. Mothers have also experienced more stress and reduced bonding with their baby when feeding is difficult. And the longer they experience those negative symptoms, the more stress they experience. For the babies, the symptoms that they have indicate that their eating is really not efficient. I've found that babies are more likely to tire easily with feeding, have more symptoms of problems in their gastrointestinal tract, such as gas, reflux, milk leaking out of the sides of their mouth, frequent spitting up, and overall discomfort. This happens with both breast and bottle feeding. I've also found that babies must work harder to eat when they have a tongue tie. So their strength of their suck is actually greater. They need to work harder and they require more energy to get the nutrition from their breast or the bottle, and they tire easily when they're eating. This research is in its infancy, no pun intended, and we are working towards a better understanding of feeding mechanics when a baby has a tongue tie so that we can develop a comprehensive screening tool that takes into account the symptoms that both the mom and the baby may experience with this anomaly. Thank you.
Thanks, Rebecca. That was really great. I saw someone put in the chat that they didn't even know what tongue tie was. And so now they've learned about it and now they know what it is. How common is it? Did you say that and I missed it? I apologize.
No, that's fine. Prevalence around 8%.
Wow. Okay, so that's a lot of babies.
Yeah.
And it's not something that they just like do a quick check. Like it would be
not universally. So right? It's really variable provider to provider if it's ever checked for.
Interesting. Well, excellent work.
Thanks.
So I really want to thank all of you today. That was really, really amazing. And if anyone has any questions that are they're just, I mean, we have a few more minutes. I know people will have to drop off, but we do have the, 6 or 7 minutes. If anyone has a burning question that they just want to ask one of our presenters, please go ahead. I'll wait a minute to see if there's any, yes, Gordia, that's a good idea. Gordia, would you like to say a few words?
Hello.
Just be glowingly proud of all the Munn Center investigators.
I am beyond proud, and I'm just so excited to have this opportunity to partner with the Research Institute and the Division of Clinical Research. And as you said, Sue, I mean, phenomenal nursing research is occurring, and I learned so much today. So I'm just excited about the opportunity to showcase these phenomenal nurses and the incredible work that they're doing. Very powerful. And I'm so glad that it was like almost 100 people,
yes,
over 100 people. Exactly. I love that.
So great. And so all of you, so many people got to hear about your important work today. I think everyone across the board did a great job of using terms that everyone could understand, and which is so important because if we're going to get the whole country back on board with understanding why science is important, they have to understand what we're doing and why we're doing it. So Maurizio, I see you right in the middle of my screen. I don't know if you want to say a couple words before we go.
No, this was a fantastic. Congratulations to everyone. Every presentation was really terrific. And, I had to say that the props that Sarah used, made me a little bit reflect on what I should be eating tonight. So anyway, congratulations, that was fantastic. And Miriam, my goodness, undergraduate, you're the youngest, so wonderful job.
Yes, great, great, great. So thank you all for joining us. I really appreciate you all coming and listening and hearing about this great work. Spread the word about all this work. We will share the video, as I said. So you all have the video. You could send it to your grandmas if you have your grandmas or your parents or whatever, so they could see. And you know, really our job here is really the reason we do this is really to teach our scientists and to talk about their work in a way that people can understand it. And you all did an amazing job this year. Amazing job. Not this year, this time. So this is our summer slam. So we'll definitely be having another one in the fall. So come, every time you see us send these out, please come and join us and listen. You know, it gives you you know, spend a little time learning about the remarkable science. And thank you to all our remarkable nurse researchers. It was really great today. And our other slammers, really, really great job. Okay.
Thank
All
you.
right, thanks everyone. Thanks for spending an hour with us. Hopefully, too bad it wasn't sunny, but I hope you all get to the beach this summer. So, okay.
Thank
Bye
you.
everyone. Thank you.
Bye.
Thank you so much.